All right, so obviously y'all can hear me. I'm gonna go ahead and get started. Over next tonight, it's gonna be kind of long. The slide's pretty big. It goes kind of in depth. We're gonna have a good time laughing about it. I guess for just the two of y'all, we'll have a lot of one-on-one. I'm going to try to start doing some stuff new. Starting at 6:30, I will lock the class from now on. I can't really do that just yet until I tell everybody. So we'll start that next time, but I'll make a good post about it. All right, so let's get started. Oh, imagine that. I think it's not working. All right, we'll go over the trauma. We talked about that before. Tonight we're going to talk about orthopedic trauma. We're going to open fractures, closed fractures, dislocations, amputations. None of it gets fun over time. Some of the patho assessment and management of upper and lower extremities, orthopedic traumas, open fractures, closed fractures, dislocations, sprains, strains. I had a funny one that, but I'm going to keep that to myself. Pelvic fractures, amputations, and replantation. All right, the medicine part applies the fundamental knowledge, basement, emergency care, and transport, stuff we got to talk about all the time. I'm going to go over the non-traumatic musculoskeletal disorders, and then we'll talk about some non-traumatic fractures. Tonight, the human body is a well-designed system in which form upright posture, movement based on the musculoskeletal system. Now, depending upon your body, your frictions, the way that you've lived your life, things are hard. Some of us have other issues with our musculoskeletal system. That's understandable. We get that, so we know that the skeletal system is very important for all of us. The skeletal system protects the vital internal organs of the body. The bones and muscles are susceptible to external forces that can cause injuries. We know breaks and strains and all that on the bones. We can also have the risk of tendons, cartilage, and ligaments. I don't know if y'all have ever torn any of those, but they're just as painful and sometimes take just as long, if not longer, to heal those ligaments and tendons. Why is my computer not working? All right. So we'll talk about the musculoskeletal injuries. Musculoskeletal injuries are often easily identified because of pain, swelling, and deformities. Although musculoskeletal system injuries are rarely fatal, they do often result in a shorter long-term disability. I mean, you could have like an ACL, MCL that can affect because, let's say you had an ACL, but you also broke your tib fib. You're going to be out for a hot minute. So here's three types of musculoskeletal. You'll have your skeletal, smooth, and cardiac muscles. So if you'll look at the difference in the ones of them, let me get my mouse out here. All right. So your musculoskeletal is very fibrous. See how it is right in here? It's got the cells that go through there. Skeletal muscles a little bit more. It's denser. And then the smooth muscles, they're all intertwined of each other because they all have to move in conjunction with each other to get the food down. Because most of your smooth muscles are all found in your stomachs, most times in your abdominal cavity. So here is, I had to read it too. So this tells you, majority of this picture just showing you, the blues going up to the heart, red's coming out. So this is blues going up is deoxygenated blood, red's coming down is oxygenated blood. That's basically here, peripheral nerve from the spinal cord. So if you'll notice, it's running down on the inside, so on the back stays right there tucked into the bone, comes down into the back side of the calf. That's really what they want to show you there. All skeletal muscles are supplied with arteries, veins, and nerves. It's important because no matter what, they make functions. They gotta have the blood, and they gotta have feeling. So blood from the arteries bring oxygen, glucose, and nutrients to the muscles. We all need that. We all need that extra energy. So that's where the glucose is coming from. When you burn those muscles, let's say in the gym, you're working out hard, it's because you're running out of glucose. Waste products, including carbon dioxide, lactic acid, all of that is carried back to the heart through the veins. So the arteries bring the blood, veins take the blood. Y'all pick up what I'm putting down? So now you know the process of which one's taking who and where it's going back and forth. Tendons are extensions of the fascia that's covered the muscles. So that's on top. Remember that. So when you talk about tendons, they're going to be on top of the things. All right. Smooth muscles. We're going to tell you how they work now. They're also called involuntary muscles. We talked about that before, that they don't need us to do it. They automatically do it. It's because it's not under voluntary control. Found in the walls of most tubular structures of the body, such as gastrointestinal tract and the blood vessels. The contraction relaxes to the control movement and the context within these structures. Those are pretty cool. Shows you there where the constricted area is. You got your lumen on the inside, your muscular cells. See how they're all intertwined with each other right in here? You can kind of see it a whole lot better. It's all wrapped up in there. Whew, thought I hit the wrong button. All right, so the cardiac muscle is a specially adapted involuntary muscle that is in its own regulatory system. Heart makes its own beat. That's what controls the beats back and forth of it, is the muscles. We don't have our, good muscles, heartbeat's going to be bad. Then the muscles of the heart's going to start wearing out. So we have all these different functions that rely on the musculoskeletal system, much less of its own involuntary system to make the heart beat. We're going to go in skeleton. We're going to start to get deep here in a second. All right, so I expect somebody to key in and say something in just a second. So on the skeleton gives us our recognizable human form, structure, our shape. We know it's made up of 206 bones. Can somebody tell me why or if there's any extra bones? The bones also produce blood cells in the bone marrow and serve as a reservoir for important minerals and electrolytes. There you go. There are some pictures. Um, the shoulders, these are, I don't know what they're trying to, just going with cartilage, is the blue parts. Thought they were dressing up for Halloween or something. So it stops here at the lower part of the pelvic girdle and makes it into the lower extremities. So just kind of touch base off something else. If somebody hasn't thought about it or done it prior, you will get your radial pulses here, your pedal pulses right where my marker's at, and that's called pulse, motory, and sensory times 4. So if you have PMS times 4, means you have a pulse, motory, and sensory. Means you're able to move your arms, you can feel a pulse, and they can feel you when you reach out and touch them. That's what your PMS stands for. Just kind of give you a little hint there. All right. So the skull is a solid vault-like structure. So this is what protects the brains. All right, Travis, while we're talking, think and tell me what the extra bones may be and who carries them. So the thoracic cage protects the heart, lungs, and great vessels. Y'all should know that because we had a big talk about that before. The bony spinal canal encases and protects the spinal cord, which y'all should remember that too. The pectorals or the shoulder griddle contains 2 scapula and 2 clavicles. All right, Travis says babies and some adults due to trauma in the feet. Ding, ding, ding. Appreciate you on that one. So the scapula is a flat triangular bone held to the rib cage by a powerful muscle that buffers it against injury. And it's not going to say that you're not going to break that right at the shoulder blade, but is a very strong. We'll show you in just a second. There's a picture coming up. I like pictures. I'm sure y'all have noticed that. So the collarbone is a slender S-shaped bone attached by ligaments to the sternum on one end to the acrum process on the other. The clavicle acts as a strut to keep the shoulders propped up, gives us our structure, gives us the form. If not, it would be kind of dropped down on top of the shoulder blade itself. Because it's slender and very exposed, this bone is very, very susceptible to injuries. I can't say septical. Y'all notice what I'm trying to say? I'm having a little issues there. All right, so look right here. This is where it's joined, right in here. This is your clavicle. I've seen this broken several times. It's very painful from what I hear. I don't really know, never broken it. I don't plan on it. This is where they're talking about where it joins into the shoulder blade right in here. Acromion process. Here's your humerus, your shoulder joint. That's if you move your arm up and down, forwards, backwards. That's the low area right in there. Hope everybody knows your sternum. Y'all have at least done CPR at least once, maybe in person, or y'all have done it in a classroom setting. The next one's your clavicle. Breaks it down a little bit more. You can kind of see without all the ribs in place. Hey, all right, now we get into the upper extremities. It extends from the shoulder to the fingertips and is composed of the upper arm. Now that is the humerus, and then at the bottom you have your ulna and radius. So the humerus connects with the bones of the forearm to form the hinged elbow joint. You see right here, also held together by those muscles. The radius and ulna make up the forearm. The radius is the larger bone right in here. And the ulna, sorry, hang on. Let me back that up. So the radius is the one that's on the thumb side. Let me make that sense. It's easier for y'all to get. So your ulna is the one that's right there closest to your body. And your ulna is the narrow little one that is, it's close to your little pinky finger on your forearm. When one is broken, the other is often broken as well. So they kind of go in pairs. They like to stick together. Haha, no pun intended. All right, so here's all the bones of the hand. Thumb, index, long finger, ring finger, little finger. I'm sure a lot of us call number 3 different, but that's what their actual name is. So the phalanges are technically your joints from the hand forward. Then you have your metacarpals, which is your bones in your hand, and then your carpals. If you're Travis, if you're born with a digit, what would it be called? I have a feeling this is going to be a good joke. What is it? And then, so if you move past the carpals, you'll have your scaphoid and your radius and your ulna into your wrist. So if you break your wrist, I don't know either, Travis. I'm sure it's something out there. Extra skin and a nub. I, I was waiting for you to make a joke, Travis. I'm sorry. So those are your bones of your hands. Um, if you ever go through A&P, some of your teachers may make you memorize, learn, whatever. Well, there's your yawns. They may make you learn all 206 bones. They may have to make you label them. I had to do that in A&P and in paramedic school. We had to learn them all, and they would test them on us at any point in time throughout the class. They were pretty hard on us. So the pelvis, and we're going to start working our way down. We've talked about the abdominal area before, so we know that you should be pretty familiar what's in the abdominal cavity. Don't forget when you start talking about the pelvis, you're also going to start talking about the reproductive organs, what can possibly also broken there. If you have a pelvic injury, also think if you have a femur fracture or here we go. So if you have a femur fracture, look in this picture, you'll notice right here, if this is broken or this entire foot has been pushed up, you're most likely the head of your femur is going to be broken, and you can potentially have your, where'd my eraser, there you go. You could potentially have a fracture into the pelvic. Most time you'll see it in the low parts here, you'll not, it's very rare to see the one here. It's not saying that it won't happen, but most of your cracks come into your smaller areas, and that is very, 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 very painful. What is it, Mickey? Now that you Googled it. So we'll talk about, we've talked about the femur, the tibial fib, and the kneecap. All those can be broken, displaced, dislodged. Go down to the foot. So the foot consists of 3 classic bone. I'm not even going to try to pronounce that, Travis. I'm sorry. I can't even try it. Hexadactyly and polydactyly. Hey, man, I'm going to let y'all have that one. My pronunciation is already off, as y'all can tell sometimes. So in your foot, you will have
Chris,
your loud
Chris, the how they call it, the layman term,
hmm,
nubbin.
nubbin. That, bruh, get out of here.
I'm serious. If you Google it, it literally says nubbin.
I'm gonna put you back on mute. Jesus, nubbin. And I don't doubt you're serious. I'm just picking with you. Oh, I gotta get my train of thought back. All right, so in your foot, you do have your phalanges again down here. It's like, oh, I'm using the big mouse. Man, come on, bro. So your phalanges down here in your toes, your metatarsals, and your calcaneus. Thank you, Travis. Yeah, you made me all giggle. We learned something tonight for sure. For anybody that's it's off topic, but right in here is where you get your plantar fasciitis. It's a muscle that attaches in here to the bone that gets inflamed. Sometimes they have to go in there and cut it. They do injections to the foot, and let me tell you, that is the closest I've ever come to shooting somebody when they stuck that needle in my foot. It was not the bestest of funnest, I can promise you. All right, so the skeletal. So the bones of the skeleton provide a framework to which muscles and tendons are attached to the body. So we got to have the skeletal system to have a structure. We got to have the muscles to make us move. So the bone is a living tissue. It's constantly growing. It's constantly learning. It can degenerate. I'm not going to say, yeah, we know it grows and gets us to our max height. And then over time, it starts to decelerate. I'm not going to say degenerate because that's not the proper word. But you got to have all the nutrients that comes from the arterial system. That's what feeds the bones. When a bone breaks, a patient is typically experiences a lot of pain. I don't know how many in this out of the nine of you have ever broken anything. I've broken my fair share, so I can promise you, yes, it's very, very painful. Um, so our joints are held together in a tough fibrous structure known as a capsule, which is supported and strengthened by key areas of bands of fibrous tissues called ligaments. Whew, I don't know why I had trouble on that one. So in moving the joints, the end of the bones are covered with a thin layer of cartilage, which we know that that's called arterial cartilage because you got to have cartilage between the bones so they won't rub bone on bone. Um, Joints are bathed and lubricated. It's the easiest way for me to say it. It's a fluid. It's a joint synovial fluid. Um, so the fluid is called synovil, synovial fluid. But I just go off joint fluid because that's we're not putting no oil in there. You can't put no more, but you gotta have it. Otherwise, you're gonna get you get old and bingy and blowed up like myself as things start hurting. So our joints allow the circular motion like in our shoulders, so we can go round and round. And our knees and elbows are hinges. So you think about this. So just remember, put it off like a door or something in your house. Circular motions like a clock, that's our shoulder. The hinges are the knees and elbows. And then we have some very minimal motion in that area. And then our no motions at all. What is the here? I got one for you. So what is the only um well, I don't know how to really say that. So the only part of our bones that have uh joints in them, and I don't mean like your joints and elbows. So basically what I'm trying to say is the sutures in the skull, those don't move. So you notice how we went over the skull before when you divided them to sections and you have the parts of your baby that grows makes their brain bigger. Well, those don't move, even though that they're held together by certain pieces and parts. They just don't move. It's one structure in itself. Significant forces that are applied against the bones, so obviously they're going to be broken. Um, that's going to be known as the zone of injury. Um, if you hit me with a baseball bat and I hold my arm up and you break my ulnar and radius, that is going to be your zone of injury. It's just something that they want you to learn. Not saying to know it, but your mechanism of injury is going to be very beneficial here. significant force has to be applied to do fractures and locations. So you don't just get those out of just every day. Right there, you see the 4 that can cause that. A direct blow fractures the bone at the point of impact. Let's see, a direct force may cause a fracture or dislocation at a distant point because let's say the shock wave may travel through it. Twisting forces are common. They cause common cause of musculoskeletal injury, especially to the anterior circulate ligament or a medial cruciate ligament in the knee. So that's like your meniscus. Meniscus is one of these. I can't remember exactly. I think it's the anterior one is the meniscus. High energy injuries produce severe damage to the skeleton. We talked about that in one of the other chapters. But obviously, since we're going over the complete structure, we want to hit it again. A patient may have multiple injuries to many body parts. Don't get zoomed in on just what you see. You may have multiples just because that arm is jacked the hell up. That may not be what their complaint is. Their complaint may be, my toe feels like it's about to fall off. Fuck, you finna treat that the chief complaint. Right toe feels like it's falling off. But brody, that left arm looks like crap. So think about that. Just because it's significant MOI is there, significant MOI is not always necessary to a fracture of a bone. It couldn't. It could just be the hands of Jesus, God, Buddha, whomever you were in there had their hands on that patient. A slight force can easily fracture just a bone that is weakened. Let's say there may be a tumor on the bone, an infection, or they may have osteoporosis. So there's multiple things that can create fractures. A fracture is a break that in the continuity of the bone, often occurring as a result of external forces. It can occur, well, yeah, so, never mind, I'll hold that. So this can occur anywhere on the surface of the bone and maybe in many different places. So it's not just going to be at the point of impact. There can be multiple places broken because maybe it was weakened somewhere else or the osteoporosis has got it. There's no difference between a broken bone and a fractured bone at all, whatsoever. A potential complication of fractures is a compartment syndrome. If y'all remember that, we know that that's potential anytime that happens. Fractures are classified as either open or closed. Y'all remember that. Your first priority is to determine whether the overlining skin is damaged or not, because that's going to make it an open or a closed. That being the case, we still need to figure out what's going on. If the patient has a closed fracture, we need to know, what is it deformed? We still have a pulse. Same thing with an open fracture. What is it like? With an open fracture, there's always an external wound that's caused by the same blow as you got struck by the ball, or a broken bone that ends in a laceration of the skin. Maybe the skin was cut and lacerated by the bone. Could be an exposed bone that you got to worry about. You're going to treat all those injuries and the breaks in the skin as an open fracture, even if it's like a green break where there's like an S in the arm. It's not a necessarily open fracture unless you don't see bone. Complications of an open fracture is to include increased blood loss and higher likelihood of infection. If we can keep it in and broken in multiple places, the way better off they are, because now they're not opening that area to introduce infection from the outside. Fractures. Fractures are also described by whether the bone is moved from its normal location or position. A non-displaced fracture, also known as a hairline, and the picture is going to show us in just a second, is a simple crack in the bone. X-rays are required. You can use a tuning fork, but just remember, this person's going to hate your guts, and that's how we tell out in the field. I've used them a couple of times when I was in the Middle East because we were a couple hours away. So a displaced fracture as an actual deformity or distortion of the limb by shortening, rotating, or angulating it. Same thing you'll see in a foot or a hip. So there you go. Painful. All of these is painful. Just gonna let y'all know straight up front. I'm just gonna say that out loud. Not today. Oh, what kind of fracture? A commuted fracture is in which the bone is broken in more than two fragments. All right. Epiphyseal is a fracture that occurs in a growth section of a child's bone and may lead to growth abnormalities. That's the reason why they're so careful of if it's broken in a growth plate. They want to do as much as they can to try to heal it as fast as they can, so there's not any issues later in life. Sorry. A green stick is an incomplete fracture that passes only partway through the shaft of the bone. And this only occurs in kids because the bones are still growing. It's gross. I can tell you, it's gross. I would rather have an open fracture than a green break. And the kid's like, look at my arm. Oh, no, thank you. I'm good. You can keep it to yourself. I promise. So you're going to have an incomplete fracture. This is the fracture that does not run all the way through the bone. It's a partial fracture, if that makes any better sense. Oblique is a fracture in which the bone is broken at an angle across the bone, and this usually is a result of a sharp angled blow to the bone. Pathologic, a fracture of a weakened or diseased bone, generally produced by minimal force. That's what some of your elderly would get with slip, trips, and falls. There it says right there, with a weakened or diseased bone, so they may have cancer, they may have osteoporosis. That's where you're going to see that break the most. Oh, I hate, just letting y'all know I despise pictures of broken anything, so that's why I hate the next 3 chapters. Period. So you're going to have a spiral fracture. It's caused by twisting force, causing an oblique fracture around the bone and through the bone itself. This is often from abuse from a very young child, like they're snatched up by their arm, they're twisted by their arm. A traverse is a fracture that occurs straight across the bone. It's kind of like it appears like it was like a knife comes straight down, tried to chop it in half. Not really say that they did that, but that usually results from a direct blow, stress fracture, maybe caused by prolonged running. That's another issue that they're saying. I ain't got to worry about that. So I'm gonna let y'all look at the top one. Y'all can handle that on your own. A deformity is the limb that may appear to be shortened, rotated. That's your top picture. You'll notice if the ankle is broke, and so is the hip, because the hip is rotated to the out. So you automatically know the hip has a fracture there. Always use the opposite uninjured limb as a mirror image for a comparison. You will not be able to pull traction on the one on the top. Sorry, it's not happening because you'll pull the foot and their ankle disconnected. So tenderness, obviously, they're going to have deformity, tenderness, guarding, swelling. So this is where your decap BTLS comes in. Got to get off the picture. Love you folks, but can't do it. Signs of fractures. They have screwed this ankle up. Bruh, you see the blood. Mickey, do not apply traction splint if a knee injury is correct. You'll separate that. I know you'll go over tractions in class or in the boot camp for sure. Talked about that last night. Fractures are almost always associated with ecchymosis of the surrounding tissues. Bruising may be present after almost any injury, and it may take hours. It could take 8 to 10 to 12 hours for this to show up. A grating or grinding sensation. Sorry. You can feel sometimes even heard when the fractured bones rub together. Yes, I chose the right field of work. I promise you, I just despise talking about it. Motion at a point where the limb there's no joint. Look, done. Y'all just have to read that. I'm sorry. Can't do it. Dislocations. A disruption of a joint in which Yeah, you're right, Mickey. I should have let you teach tonight. I can't do it. All right, so you'll have supporting ligaments are often torn from a dislocation. Sometimes they are completely torn. It could be a partial tear too. So this is going to allow one of the bone ends to separate completely from each other. So the tendons may have to be reattached. A fracture, a fracture dislocation is a combination at the joint in which the joint is dislocated and there is a fracture at the end of one or more bones. Sometimes a dislocation joint will spontaneously reduce or return to its normal position. You'll see like somebody pop their shoulder out of place and they'll pop it back in. You're not supposed to be able to do that because you've lost a lot of cartilage, and that's probably why you're able to do that. Uh, uh-uh, uh-uh. Sometimes if you just happen to move the right way, it'll automatically pop back in. Still need to go get checked out. You may get seen by a specialist for sure. You'll be able to confirm the dislocation just by doing a good assessment. Um, Sometimes a dislocation uh, is not going to reduce and does cause problems. It's very painful. It is associated with joints around the shoulders, the fingers, the elbows, and the knees. Those are your biggest ones that pop out. So some of your signs and symptoms of dislocations are all written right there. I'm gonna let y'all read that while I take a big old swig of water. Next. So a sprain. A sprain occurs when a joint is twisted or stretched right beyond the point of its normal range. And then you'll start to get all the bruising. You'll have supporting capsules around the ligaments are stretched and torn. So it's right there at its limit and then right there and it's done. A sprain should be considered as a partial dislocation. Sometimes it's not, but it's that line, it's that little gray line that that ankle's at. Sprains can be mild or severe. It can require you to be on crutches and a boot. You could be laid up. Just depends. Um, After the injury, the alignment generally returns to a femoral normal position. Sometimes it could be so bad that you should see a specialist and get realigned. Um, Sprains do not usually involve a deformity of the ankle, knee, or shoulder. There is a limited pain, but it's not excruciating. You're going to make it. You'll be fine. It's just going to be uncomfortable. As you can see right there, that's a sprain. See how the blood's pooling around where it's had the injury. They are going to guard this. You will see the swelling. Most of the time, you'll get the call. Foot's going to be propped up in the air. Ice is on it, and they're going to have pain. Instability of the joint. They're not going to let you touch it. It's not happening. Well, here, I need to assess it. No. It just, sometimes you're just going to have to take their word and be like, all right, next, game on, because you just hang it up. Wait till y'all see this next one. So a strain is a pulled muscle. We've done that at least, I guarantee all of us have done that at least once in our life. We've strained something. It occurs because of a normal contraction from an excessive stretching. Strains may range from a minute separation to a complete rupture, and that's where the ligament pops. Unlike a sprain, no ligament or joint damage typically occurs because it's got that uh, little fibrous materials and it's able to spring back, kind of like the elasticity. Often no deformity is present of a strain, and you'll notice some minor swelling and some pain and some guarding to that at that injury site. Some people are going to complain of increased pain and movement. As long as that extremity is not moved, you're going to be fine. A lot of patients do have pinpoint. Oh shoot, sorry. Where are we at? I'm on my own screen, so you'll have to excuse me. All right, remember I love y'all. So amputations. Now, it's not. Now we think of an amputation of the skin and it's gone, done. But an amputation is an injury in which the extremity is completely severed from the body. Now this is an avulsion. Right here is an avulsion of the skin, so it's got ripped off, torn off. That appears on my screen to still have a fingernail, so not sure I'd call that completely amputation, because mine, I would just assume like zip, done. Travis, them strains is awful, especially if you don't stretch to warm them up before sports workout. Wait till you get older, bro. Biggie, chest muscle strains are horrible. Lifting weights, I've seen a lot of weightlifters do that. Trying to pick up something a little heavy sometimes. I think that's possibly it. Next. All right, some complications here. Your orthopedic injuries can lead to numerous complications. Obviously, you saw the picture. Look at that. It's not gonna be nice. Uh, they're gonna do skeletal injuries, but they're gonna also have systemic change or illnesses. And what I mean by that is it's essential that you do not focus just on the skeletal injury. You need to focus on everything that may be underlying to keep your brain from going, oh my God, oh my God, oh my God, okay, let's check this. Oh my God, oh my God. Gotta keep on. Gotta press through. The likelihood of having complication is related to so mm, y'all can read that. I think that's pretty good. I'm trying to figure out what they want me to say for there. All right. So to prevent contamination of an amputation, try your best to clean the site from any debris. Don't take your forceps and try to pick the grass out of it, the gravel. Let somebody else do that. Especially let somebody knock this person out with some narcotics where they can't feel it, and let them be at the hospital when they decide to do all that uh, cleaning of the body, because that's not, whew, it's not gonna be nice. I can promise you. Um, some complications. It's You're gonna possibly help prevent further injuries, reduce the risk of wound infection, minimize pain by the use of cold and analgesia, which is pain medicines, and transport them to the most appropriate facility. We know ultimately that is our goal, is to give them some care, some calming measures, and get them to the correct facility. Probably going to need a lot of ALS provider. If you have this, the faster you get them there, the better off your patient can be for pain medications. Then you got your golden hours. For some, we've talked about this. This is the golden hour, and this is critical for life and for preserving limb viability. Because the faster we can get them there, the faster it is, and the most amount of time that they have to reattach that wound and limb, it may be better off for them to have no deficits from the prolonged injury. In an extremity, with anything less than a complete circulation, prolonged hyperfusion can cause significant damage. Any suspected open fractures, y'all can see, is critical. Remember, the most injuries are not critical. You can use a musculoskeletal grading system in your book on 31-1 to identify critical injuries. I don't know what that is. I ain't got no book, so y'all gonna have to look that up. All right. Yeah, Austin, it's all your fault. We've been sitting here waiting on you, bro. I know you're late. Now I'm just messing with you. It's all right, man. We all got lives. We gotta live them. I just can't wait till Tuesday to get off this rig. So that's all I'm waiting on. Counting days down. All right. So your patient assessment. The biggest thing I want you to do is you got to be able to distinguish a mild from severe injury. Some of your severe injuries may compromise neurofunctions, and that could threaten some long-term functions. Make you even starting in on it. Come on now, leave the boy alone. He got to work. Um, Always look at the big picture, y'all. Don't get tunnel vision. Don't get focused on. You need to evaluate the overall complexity of the situation and what life-threatening threats that there are. Are there any? Is there anything else that can give you a threat? Scene size up. Biggest thing is here is check your MOI. We know that pray to God you get out of the truck with the proper PPE on that you're supposed to have. This PPE should be it's like getting out the truck or your car with your wallet and keys. You always need them. Um, Here, evaluate for additional support. And is there any chance for some underlying bleeding that you're not going to see? And it may be hidden. Some more what indicators for MOI. I want you to just basically look for your primary secondary injuries. So your secondary injuries are a result of what happened after the initial accident. Remember, you can have an explosion, which is primary. Secondary from them being blown and hitting the concrete wall, that's where they got their TBI from. And tertiary is if something else happens that lands on them, impales them, those are all considered tertiary. Your primary assessment, what I want you to do here is this is what I want. Just remember your life-threatening, your ABCs, and treat ABCs and life-threatening first. I ain't really got to ask about their chief complaint. If I can see they're having difficulty breathing, or they have an arterial bleed, I ain't got to ask. It's done. Administer high flow O2. Whew, because as soon as the brain starts becoming deficient of oxygen, that's when this patient's going to change their LOC. The decreased LOC is going to affect their overall general ability to help you as a provider. If you don't give them that oxygen and keep their brain oxygenated, well, you're going to hurt yourself because it's past time that this brain is like, hello, I need some oxygen. Then it's going to just kind of drift off and do its own thing. And eventually they're going to die when you could have just easily stuck that mask on them and kept on. ABCs, assess their breathing. If they have any impalement, the only time you can move it if it is in their cheek and it's affecting you to apply the mask, the OPA, NPA, or the BVM. That's it. That's all you can do. It's the only time you can do it. Circulation. Stop the bleeding. Maintain normal temp. I know that we always going to try to expose the injury. I need to expose the chest, expose the arms, cut their clothes. That's what everybody wants to do. It's like, got a new pair of scissors. I got to use them. But eventually, if it's South United States and it's hot, it's 500 degrees in the shade. It's 3,700 degrees on the asphalt. Come on, boy. You got to maintain that temperature. And then when it gets cold, think about that. That you're going to turn around and be like, oh, I'm going to cut the clothes off. Well, did you think about having a blanket handy? Did you think about getting them off of the ground where it's, I say 2, but it don't barely get down to 2 degrees here, where it's 28 degrees, and put them on a stretcher where you can wrap them in a blanket? Think about that. So your transport decisions, this patient has to go to the most appropriate facility. If you have to bypass a facility, that's okay. Just make sure you follow what your local agency says. Spoke with a fellow today from New York. It's okay to pass one facility, but if you pass another facility and you didn't contact med control, they're going to be wanting to talk to you and wondering why you took that patient elsewhere. Now, again, this young gentleman is from New York City, and they have level 1 trauma centers on every single corner, so I understood what he meant. If you can obtain a history, go from your sample and your OPQRST. I was just saying, OPQRST is too lengthy when ABCs require media. Then don't ask. Let it go. Don't ask no questions. just treat them. You can always go back and get a history a little bit later. Just because you got an hour downtime at the hospital doesn't mean you can't get information from the hospital. Maybe you weren't able to find his name out or how long he would have uh, onset provocation quality. So let's say you don't know how long it was when he had his arm cut off, but you can probably find that out at the hospital when family shows up. Secondary assessment. This is ongoing. Continue. It's more of a detailed assessment that you're going to do after you treat your life-threatening injuries, and you're able to take time to each extremity, the head, the chest, pelvic, the legs, the feet, check their back again without trying to, endanger yourself or the patient because you're trying to log roll them. This is here in the secondary assessments when you treat your non-life-threatening injuries. Let's see here. You must assess your neurovascular function every 5 to 10 minutes during the assessment, depending on the patient's condition until he or she is at the hospital. Always recheck the neurovascular function before and after you splint or otherwise manipulate a limb. You only get one chance to set that limb in an anatomical position and obtain a pulse. If you set it once, there's no pulse, you got to leave it alone. You got to splint it in that position. If there's a pulse in the beginning, you align it to the most anatomical position, you get a pulse. You better not let go of that sun gun. You better have somebody ready to splint. Don't be the only sun gun in the back of that truck, because you stuck right now, Chuck. Got to make sure you hold it. So the 6 P's of musculoskeletal assessment is pain, paralysis, paresthesis, which is numbing or tingling, pulseness, pallor, and pressure. That's your 6 P's. You want me to say that again? Yes, Chris. Oh, I'm sorry. I had to talk to myself since somebody else is. Pain, paralysis, paracenthesis, pulseness, pallor, and pressure. What time is it? We got time. Vital signs. We know that. I'm not going to sit here and talk about. That's 5 or 10. It's Q5, Q10. This says here every 15. We're going to stick to 5 and 10. Let it ride. Reassessment. The main goal is to stabilize in the most comfortable position that you can get. If you've got pulse and circulation and you're like, that arm's not supposed to be there. Yeah, Travis, I've already yawned. I promise you. I just trying to talk and keep going and pause when I can. But yes, I've been yawning, so I wish I could get a nap, but no, I'm still at work and we've been very, very busy here today. But I'm gonna try that one day, get a nap, and then come and teach, see how that works out. Probably won't ever be able to happen that way. Communication, documentation. And I'm gonna say, I'm always gonna say it. If you don't document it, it didn't happen. Period. And that's on you. When you go to court and they ask those questions, you're like, yeah, I did that. Well, Mr. Green, it's not in your report. You sure you did that? Well, yes, sir. Whoa. So you're saying you did something and didn't write it? So they're gonna check you on character. So I can promise you, sitting on that stand sucks. I've been there and done it. I don't wish it on nobody. They try to do everything they can to make you look like you're incapable of doing your job. Document, document, document. If you did something, you need to document on it. Emergency care. Perform a primary assessment. Prioritize your injuries when you do that. Stabilize the patient and do your ABCs. Assess the entire body. Always follow what your standard precautions are. ABCs, do your normal hospital's information. If your protocols say do this, don't deviate from your protocols. Just because you think you know, if you have not been trained and your agency does not allow it, you can't do it. Make sure you be alert on for internal bleeding. Stay on top of those vital signs. If you notice a rapid change, that could be a sign. If you're noticing that their bellies are swelling and they're very tender, that's why they're guarding. You could suspect a internal bleeding. So some splinting. I'm gonna let y'all read that. I am very dry mouthed. I gotta get some drink. So a flexible or rigid device. Somebody give me some ideas what a flexible or rigid device is. Oh. I'm gonna start calling some names out. Somebody say something. All right, let me see who's here. I'll start calling names out. Austin, can you hear me? You can type if you can hear me. I hope you can hear me. Y'all in here. Metal splints. Good job. So, a lot of your agencies have gone towards cardboard splints, and the reason why cardboard splints, y'all can just imagine how cheap that really is. But when you pay for it as a patient, you think that's the highest. That cardboard's got to have gold in, because they make it think like it's gold. Padded board splints, perfect. That's your cardboard splints. Sometimes your agencies will have other types of splints. You may have the airbag splints, which means you put them in like a sleeve and you pump it up, and it's like a air splint. Some agencies may still have some old Thomas packs, and some of the Thomas packs have the metal. We call it metal stairs in them. You can use a. I just went blank. Mickey, what's the device? It's orange, flexible. Oh boy, I just went blank.
Say that again, Chris.
What's the padded splint? It's orange. Uh, you can adjust it, make it move it in any position you want.
Sam Split.
Yeah, yeah. See, I just had to talk it out loud. Y'all knew what I was talking about.
See, I knew somebody knew.
Oh, he working or on a truck. Probably forgot his computer. No, I'm just messing with you. Sorry, bro. I had to pick on you. So Sam splints are amazing. If your agency has them, I'm pretty sure Rob's got them in that big ass trauma bag that he's got. He's gonna be bringing to class. So play with it. Put your hands on it. You gotta know how to use these tools. They're freaking awesome, man. They can do almost everything that you need. Uh, you can splint for anything you need. Like prime example, anytime that I have a cardiac arrest, I put my tube down, I get my tube situated, get it tied off, and I put a C-collar on. That is a splinting device, but I use it for something else because I get to hold the head in one place, and I have something to tape my tube to, and it's secure. It's very hard to move the tube once you've had a C-collar on there. You don't want to wrap something that's super tight that you're going to restrict the blood flow. So make sure you check the pulse prior to splinting and after splinting to make sure you still have a pulse. Um, General rules right there. Remove the clothing. Do not move the patient before splinting an extremity unless there is danger. Life over limb, bro. Life over limb. If I gotta yank this patient out of the way and pull them to safety, I'm not worried about their ankle that's all tore the hell up. We gotta get to safety, then we can handle that later on. We talked about pads and rigid splints. Maintain manual stabilization if you can, and you have a pulse. If you grab the ankle and you're just trying to move it, and you realize like, oh, I got a pulse. Hey man, I can't move. I need you to go grab this, this, and this, and let's splint it. As long as it's not impeding from a life-threatening injury or their ABCs are compromised. Remember that. I told you.
Hey, Chris, another thing I want to add, whenever you're applying a splint, if this is part of your skills, if this is part of your state exam, make sure if you're going to apply a splint that you say, I will have my partner hold this splint in place while I apply the bandage, and then make sure you reassess everything every step of the way, because that will fail you right away if you do not reassess.
Do y'all understand what she's saying? I'm gonna let y'all type on that one. Do y'all need some more explanation on that? All right, Sherry, you good for that? Okay. All right. So very, very good point. Y'all, it's been a hot minute since I've been at a registry station. So Mickey, I'm glad. Thank you for bringing that up. That's an awesome deal. Rigid splints, two situations which you may splint the limb and the position of deformity. Yes. So when the deformity is very severe, or you encounter resistance or extreme pain when applying gentle traction to the fracture of the shaft of the long bone, leave it in place. Most dislocations should be splinted as found, but follow what your local protocols are. Don't just rely on what Chris Wally said. All right, formable splints, they are comfortable. Uh, they do provide a uniform, which means they're padded all the way around in the same place, the same air. Sometimes, like I said, you can inflate it, the splint after applying it. The air splint is comfortable. It does provide uniform contact and has advantages of applying firm pressure to a bleeding wound. If you ever use an air splint, you ain't getting it back, Holmes. It's gone. Some of your drawbacks, the zipper can stick, they can clog with dirt. I'm not sure how they freeze if they don't have air, water in them. Significant changes in the weather or altitude affect the pressure of air in the splint. Because if you go high in the air, the air is gonna expand. If you come down, if you go up, the air is gonna dissipate. If you come down, the air is gonna expand. We could go into a whole depth of that when you start talking about vent patients and flying versus at what altitude you need to fly at. I've been to FPC once or twice. We have some vacuum splints, pillow splints, structural aluminum malleable SAM splints. I guess that's what SAM stands for. Ha ha. We'll let that alone. Sling and swath, which is your triangular bandages. Pelvic binders. Pelvic binders are freaking amazing, but they are very expensive, folks. Very. Hey, before I start the next slide, we're done at this one. Let's take 10 minutes. I will see you back at 8 after. Any questions? Back in 10, folks. Now, give me just a second. I'm back. I just got to look something up. All right, start back over here. Let's get going. All right, so traction splints. So what we're going to do on a traction splint, this is the application of an inline traction. So what we're going to do is we're going to pull on a body structure in the direction of its normal alignment. It's the most effective way to realign a fracture of the shaft of a long bone so that the limb can be splinted more effectively. You can only do this on the legs. Traction splints are used primarily to secure fractures of the shaft of the femur, which are characterized by pain, swelling, and deformity of the mid-thigh. You'll know. I don't even know how else to tell you. Besides, as soon as you look at it, you're like, oh, Jesus, that looks like that hurts. Sometimes it can be a little like the legs are swollen, and they're like, oh my God, you pull just a little bit on that ankle away from them, bruh, they're going to love you. They're going to try to marry you after it's over. When applied correctly, traction stabilizes the long bone and improves the overall alignment of the limb. Do not attempt to force the bone fragments back into alignment. Don't worry about it. So in the field, the goal is the goal of inline fractures. We're going to stabilize the fracture. We're going to align the limb and avoid any further potential neurovascular compromise. So what that's meaning is we don't want to cause any more damage to the tissue. We're going to let it rock out the way that it is once we pull traction on there. It's the best way I can tell you, folks. We'll show you in just a second. Here's a picture. Do not use any for the upper extremities. Anything causing pain to the knee of the pelvic, because you're going to be pushing against the pelvic. Partial amputations or avulsions with bone separate. Oh, never mind. Lower leg. Here's a picture. Look. All right. So you see right here. There's my mouse. How this is the normal function. The legs are in alignment right here. This one is broken right here at the femur. This area right here is going to be swollen and very painful. All right. Before you apply traction splint, be sure to control any external bleeding. The amount of traction that is required varies, but it will not be any more than 15 pounds. Use the least amount of force that is necessary. All right. In the picture, they're grasping a hold of the foot. Grab the feet with your hands, and you should not stop until the limb is fully splinted. Now, if you pull it this way, you're going to have to hold it this entire time. So if you realize that you're going to put a traction on there, you're going to want to try to rig up the long bone, the traction splint initially. Don't pull traction, and you're gonna have to let it go because now you got to splint up. That's just no. It's gonna be even more pain, I can promise you. So the pelvic binder, they have mechanical ones that work really good, but I can promise you the best thing that I have ever used is a sheet. You take a sheet, fold it long ways. I actually just take end to end. Me and my partner just kind of twist in opposite directions. And then when you get it to where you want to lay it underneath the patient and kind of pull one side, you're basically pulling like seesaw method, trying to get it underneath the pelvic area. Spread it out just a little bit, make sure it gets a good comfort. And then tie the sheet as tight as you can in a knot. I don't know how else to tell you besides just show you. And there ain't nobody in here for me to show you on. So we'll make sure I'll drop that in the box for Rob to show you guys at boot camp. I don't know if y'all notice, I ain't going to be at boot camp for you guys. I'll be offshore. So I'm sorry about that. I know you're going to miss my face for some that you've never seen it. but don't be upset. It's all right. Some hazards. You might, you could potentially cause nerve damage. It's unseen. You don't know. You're trying to do the benefit of the patient, so it's not like you purposefully did it. So that's okay. You're gonna your primary job is to reduce the reduction of the distal circulation. So that's okay. That's what we're trying to do. Uh, you don't want to aggravate the injury, but he can video chat. Girl, quit playing. See, there's a few that in here that miss me. I think Mickey don't. She just don't want to take me to eat no crawfish is what it is. So injury to the tissues, nerves, blood vessels, and muscles is probably what's going to happen. Now, our overall job is not to cause any more, but we might. I mean, it's an unforeseen issue that we just don't know that's going to happen, but we're trying to do the best for the patient that we can. Transport. Unless it's a trauma, y'all, I don't ever see you needing to run lights and sirens or even put them in a helicopter. I mean, if you think the bellies are swelling and they bleeding internally, maybe, but it's ground and pound them if they've broken a hip. Yeah, let's cake them. You know, I've actually transported a femur fracture 45 minutes by myself, and I ran out of morphine, but hey, they were comfortable, and I had 3 vials of morphine, so I didn't have to worry about it. They were comfortable all the way. Huh? That was a good trip. Um, Scapula injuries, clavicles. Oh, children most of the time will damage these. I don't really know how they break them, but I know more children are more common to that. I've seen 2 adults that have broken theirs. They say that's the most painful thing that they've ever seen. It's the clavicle is the subcutaneous. Uh, Hold on, back that up. I didn't like the way that said. So the way to realize it is a general swelling and pinpoint tenderness over the clavicle is the best way to figure out if it's a broken or not in that area. Um, Fracture of the scapula occur much less frequently because of where it's at, and it's by a large muscle. So you're going to be protected by that. Most of the time, our shoulders are used pretty well. So you have, I'm not going to say you got amazing traps, but most of us have pretty, our shoulders are pretty decent size just because that we're using our arms on a regular. There's the yawning for whoever asked. Here's the using of the sling and swath. I have been doing this for 20 plus years. I've never been able to do the sling and swath. I can't get it right. I know it looks very simple. I'm gonna mess it up. Thank God I didn't get that from my random station in paramedic school. But oh, come on, Travis, come on now. Uh, I I'm gonna have to. Well, Mickey, since you did, you want to give some life stories on it? Cause I just hate it.
So I'll give a little bit of advice on this station. They give you, what is it, 10 minutes per station.
10 minutes
But you have
for
all you want to prepare your bandages. So you get to figure out what you have, what you need, and how you're going to do what you need to do. So you need to just pay attention to how long your bandages are, what you need to do, and how many you need. Because if you need more, they have to go get more. Because this is a station that can fail you very quickly.
Is that all the words of wisdom you got?
I mean, it's not one that's stressed
No,
at clinicals. Like,
I'm gonna point for you. Will probably do this on a clinical. Period. You're not gonna happen. You will probably do this at the skill station if it's chosen, and that's it. I'm just saying.
It's one of those that they choose at your state test because you don't see it in the field a lot.
Yeah.
Just remember to reassess everything that you attach.
Attach? You trying to reattach it with some stitches or what? I mean, come on. I'm just picking. She's right,
I'm
y'all.
telling you.
Pay attention to what you do. So dislocation of the shoulders, most of the time it's going to be at the humeral head. Humeral head is not, and it's going to dislocate anteriorly. You'll notice basically it's a big knot in the shoulder. It's super, super painful. Splinting of the joint, you may just have to do it whichever is the easiest and comfortable to that patient. I have done it once, and I've just been like, hey, you tell me what's comfortable, and we gonna situate you that way. And actually, when I got there, the man had a belt around his shoulder and underneath his other arm, and it just pulled it tight, and he held it in place. And guess what? That's how we rode to the hospital. He was comfortable, super comfort. So fracture of the humerus, fracture of the humerus occur either proximally in the mid shaft or distally at the elbow. Fractures of the proximal humerus resulting from falls are common among elderly. Fractures of the midshaft occur most often in young patients, usually as the result of a violent injury. Support the site of the fracture with one hand, and with the other hand grasp the two humeral condyles just above the elbow. I have no idea what they saying. So look, watch this. Skip. Oh, there's a good picture coming up. How about this? So you can just tell that's a fracture. You know where he's fractured at. He's rotated distally. He's in a lot of pain. Next, elbow joint sprains. Uh, you're gonna have to put that arm back in place. I mean, in a not in. You don't want to get the shoulder back in place because it may or may not happen. But you can't transport the guy like that. You can't stabilize the guy like that because when you go to put him in the ambulance, that arm is going to be against the wall. So you have to move them of some form of fashion. And the thing is, you may have to medicate them prior. So that's probably going to be the best way to transport them. Fracture of the radial head, often missed during diagnosis. This fracture generally occurs as a result of a fall on an outstretched arm or a direct blow. Hey, give me 10 seconds or 10 minutes, y'all. I got to take a break. Hey, sorry about that. Had a guy come back by for a recheck. I don't remember what I was saying. So let me go back to this. Mickey, how many stations there when you do your test? Come on. Yes, you have to pass them all. You should already have all of the National Registry skills. You have to do every single one of those and pass them with no non-critical mistakes. If you hit anything with a critical mistake, it's automatically fail. It's automatically failure. Uh, that's if you don't have them, please do your homework. Get all the National Registry skills stations. I'm pretty sure that they were sent out to y'all in the original get-go. So you need to start looking. You should have been looking over them. So elbow injuries, always assess distal function periodically in the patients with elbow injuries. Make sure that they're still got their finger movements. They can move all their distals, their fingers pretty well. If you happen to find a strong pulse and a good cap refill, splint the elbow in the position in which you found it. Make sure you mark where you feel the pulse at. Further care of this patient must be taken to a med facility. They got to have an MD do with them from after that point because we've only done what we can do. So fractures to the forearm. Fractures of the shaft of the radius and the ulna are common in all age groups. But you see them most of the time in children and older people. Usually both bones break, so that's the radii and ulna at the same time, result of an outstretched hand again. An isolated fracture of the shaft of the ulna may of course occur as a result of a direct blow. We call that a nightstick fracture. Fractures of the distal radius, which are especially common in elderly patients with osteoporosis, are often known as Colles fractures, C-O-L-L-E-S, Colles fractures. The term silver fork deformity is used to describe the distinctive appearance of a patient's arm. You can stabilize a fracture of the forearm wrist, which uses a padded board, air vacuum, cardboard splint, magazine, whatever you can get to make it feel comfortable. Splint it. You got to confirm everything by an x-ray, no matter what. We don't have that in the field. You can't blink your eyes twice, put your sunshades on, and get a view. Can't happen. Don't worry. So take them to a facility that can do that. So often fractures from the pelvic, direct compression of the form of a heavy blow, a fall. Fracture of the pelvic may be accompanied by life-threatening life of blood loss from a laceration of a blood vessel that may have been struck by a pelvic bone. Several liters can drain into the pelvic space and the retroperitoneal space. As a result, significant hypertension, shock, and sometimes death can occur from these from fractures. You must take immediate steps to treat the shock. If there is only minimal swelling, you're probably not going to know it. You're just going to see fractures of the pelvic. You're just going to see shortening and rotation of the feet and, well, foot, unless it's a both-sided fracture. You'll notice the feet will just be rotated outward. You'll have one that points straight up and down, and one that'll be shortened and to the right or to the left, depends if it's the right side or the left side. That's going to be your signs that you're going to see when you walk in. However, the pelvic fracture fragments can lacerate the rectum and vagina, creating the open fractures that is often overlooked. We ain't going to see that, so I don't really know how else we're going to feel that. If you suspect a fracture of the pelvic, you're always going to check for decap BTLS. You may check for, they're going to tell you pain. They may urinate or go to the restroom on themselves because they may have had a rupture. They can't hold it. They can't move. They may have been down there for a while too if they're elderly. Here's some pictures on how to assess the pubic. Now, this one, don't do that. Just period. That is not how you do it. This you want to grab right there at the waistline, push inward. Sometimes you will be able to tell if they're like instantly saying, ah, and they start to feel better. You will also feel like a grinding motion. If you do a pelvic girdle rock, they don't really like you to do those rocks anymore, or pushing down like this one. This one right here is not cool to do. This is the one you want to do, push in on both sides equally to see how it is. You can push in and down just a little bit, but be very, very cautious, because if any of this is ruptured right in here, you may cause further damage. Dislocations. Most dislocations are posterior. That is correct. Most commonly occur as a result of a motor vehicle crash in which the knee meets the direct force of the entire femur and is driven posteriorly. You should suspect a hip dislocation in any patient who has been in an automobile crash and has a contusion, laceration, or obvious fracture to the knee region. The sciatic nerve is the largest nerve in the lower extremities. Can have some damage to this. It controls the activity of the muscles in the posterior thigh and below the knee, and the sensations of most of the leg and foot. Some people can say, or most people as now can say that I have sciatic nerve damage, and you know what they are because they run sharp pains down the leg. You can have some numbness to the feet. So just think about if they dislocate the hip and they pinch that, they may not be able to feel that, feel the tenderness or the numbing in their feet if you go to touch their toes or something like that. They're going to have severe pain. Patients typically lie with the hip joint flexed to the thigh, rotated inward towards the midline over the body and the tip of the opposite thigh. I don't know what it's trying to tell me to tell you. The patient will have severe pain. There we go. The lateral and posterior aspects of the hip region will be tender on palpation. So let's talk about that. The lateral and posterior parts of the hip. So that's the outside and the back is going to hurt the most. Occasionally, sciatic nerve functions will normal at first and then slowly diminish. So that means that something has broke it, penetrated it, and or compressed on it. Some more dislocations of the hip. You're going to splint it the best that you can. Sometimes a lot of agencies have got away from backboards. You definitely want to support the limbs with pillows. You want to fill that gap. Don't let the just put as many pillows, blankets, whatever you can to support the hip and the legs because it's very painful. And just, you ain't got to go license arms to the hospital. Just transport the patient. They may take some medication, so the ALS provider may have to ride with them. They may just be chilling and you just riding back there, or your service may let the ALS provider load them in with a narcotic dose and you transport. It'd be easy transport because I promise you the patient is going to love you after that. Fractures of the proximal end of the femur are common fractures, especially, like I said before, in older patients or people with osteoporosis. So if the break goes through the neck of the femur, and across the proximal shaft of the femur, patients display a very characteristic deformity. They lie with the leg externally rotated to the out, and the injured limb is usually shorter than the opposite uninjured leg. Oh, Chris probably told y'all that. Y'all remember that now? No, I'm speaking. So that's, what did I do? Stand by. I gotta find. There we go. Toggle my hands and change all on my other slide. So that was that. So we're going to assess the pelvic for any soft tissue injuries and bandage appropriately. Pad the areas. The age of the patient and severity of the injury will also dictate how we splint that injury. All patients with hip fractures may lose a significant amount of blood. That is a closed injury. You should treat them with high flow O2 and you check their vital signs. Be alert for a change of vital signs and treat for shock. Oh, snap. Stand by. Doing it again. All right. Fractures on the femur can occur in any part of the shaft, from the hip region to the femoral, just above the knee joint. Mickey, just remember, if you are told, oh, they broke the hip, most of the time, the hip broke and made them fall. Correct. Most of them, that's an elderly patients, and that they slip, trip, and fall, and when they land, they just bloop, crack, done, broke. So there's often a significant amount of blood loss, such as 500 to 1,000 milliliters after that fracture. All right, so everybody think about this. So you know the IV bag you hang up in the back of the truck on 99% of the patients. We're talking about the big bag. That's 1,000 milliliters. That right there can leak into because of a femoral injury or femoral break. That's a lot. Holy moly, think about that. So what you think? We're going to see some shock from that? Probably so, because that's a lot of blood, bro. Bone fragments. Because of this deformity, these fractured bones and fragments may penetrate and press on important nerves and vessels. So a lot of times they do have nerve damage from these fractures. Femoral fracture is nasty. It's very nasty. It's very painful. If the foot or leg below the level of the fracture shows signs of impairment, you notice you start to lose circulation, starts to lose color. Apply some gentle longitudinal traction, that's in line, to the deformed limb in line with the long axis. So basically you want their toes pointed up towards the sky, and you want to pull down and gradually pull the leg from the disformed position. A fracture from the femoral shaft is best stabilized with a traction splint such as a Sager splint. Those are freaking amazing. They are a contraction now. You don't get in no dang hurry when you put them on there. And you go to get them in and out of the ambulance, you don't get no hurry because they stick out further than the foot. And if they a big old fella, I mean tall, be careful when you shut that door. If you hit that foot, you done messed up now, because they gonna hate your life. They gonna hate everything about you because you are getting in a hurry. So knees, this is where we talked about ACL, MCL, meniscus, all those things that happen in there. And those are all ligaments. Dislocated kneecap. I hope to God I never have one of those. They just look painful, y'all. That just looks uncomfortable. Mickey, I know you're talking about the leg, but you're right. Still, on this dislocation of the knee, they hurt. They rough. Massive swelling. You can have some bleeding occur around there, some ecchymosis. They are going to point exactly and say, I hurt right there, because it hurts right there. You should splint all suspected knee ligaments and injuries. The splint should extend from the hip joint to the foot, stabilize the broken bone above the injured joint and just below the knee. I've never splinted one of those or seen one of those splinted, so I can't even tell you how you're going to splint that, y'all. I'm just being honest. That ain't going to be a skill, I can promise you, how to splint a knee, so you can hang that one up. There are true emergencies just like on any other limb. When the knee is dislocated, the ligaments that provide support are going to be torn. The proximal end of the tibia is completely displaces from its juncture, which the lower end of the femur is usually producing significant deformity. You can have that in baseball injuries, football, wrestling. I'm just going to go with every sport. I mean, you can have that in volleyball, cross country. I mean, heck, now they got bass fishing in school, so I'm sure you can do that too. Mess your knee up doing that. Posterior knee dislocations are common. Most of it's occurring in all kind of the cases there. Commonly, the anterior and posterior ligaments are damaged. Medial dislocations result from a blow to the lateral part of the leg. Somebody probably messing with you and try to kick your leg out from underneath, you can mess it up. Patients would typically complain of pain to the knee. Report as my knee has given out. They got some joint instability. The injuries to the nerves, not like your nerves, but the nerves. Y'all know. Hang on one second. I'm going to look at something. All right. All right. So fractures about the knee may occur to distal end of the femur, at the proximal end of the tibia or patella. The management of these two types of injuries, if there's adequate pulse, no significant deformity, splint the limb just with the knee being straight. Sometimes they may be in more comfortable position with the knee bent, but keep it as straight as possible. If I don't want to say you wiggle around the kneecap, because I'm pretty sure that's not going to be comfortable either. You may need to apply some ice to the area. Put it in just in a position of comfort. It's going to help you out the most. If the pulse is absent or below the level of the injury, suspect a vascular, which is going to, you'll notice that, because you should check for a pedal pulse no matter what. If you think that there's no pedal pulse, always have your partner check it to make sure that you're right or wrong. And if that's the case, remember you only got one time to do realignment. If you don't gain a pulse on the first time, you may just have to slowly let the traction go, splint in the position right that you found it in, and transport to your facility. Dislocations of the patella. It's going to be most of them are teenagers. They say athletic activities, soccer. That's most of the time you see them in soccer and football. You're going to splint the knee in which position you found it in. Most often it is with the knee flexed into a moderate degree. Let's say not in a seated position, but maybe the knees like in a 45, the legs in a 45, sorry. Sometimes they can hold that position. You may have to apply a padded board splint, but just try to secure it the best that you can. I wish there was the picture. I'm better at pictures. Let's see. Often fractures of the shaft of the tibia or the fibula may occur at any place between the knee and the ankle. Often both bones are fractured at the same time, same thing as the arm. Even a single fracture may result in a severe deformity and significant angulation or rotation. Open fractures of the tibia are relatively common. Sorry, I knew I was wrong when I said rarely. Correct severe deformity before splinting by applying gentle traction. These fractures are sometimes associated with some internal injuries, but they do resort to a distorted position of the limb. They growth. Realigning the limb restores functions of adequate blood supply to the foot if it's done correctly. If it does not provide you with the pulse, you need to transport promptly and notify med control. Notifying med control is going to tell you if there's going to be an ALS provider meet you there, or what facility to take them to. I've broken both my ankles like 6 times, so I'm very common with these. My ankles suck. It's very hard for me to wear flip-flops because I'm like, oh, look, there's a curb. And I break my ankle just looking at it. Any ankle injury is going to produce pain, swelling, and localized tenderness. You ain't going to be able to put weight on there. You're going to either have to go to the ER or emergent clinic, whichever one's in your area. Most common injury is a twisting. That's going to tear the ligaments of the ankle, that's where your inflammation comes from. Y'all know, if it's open injury, fix it. Check for that distal pulse. If it looks like hamburger meat, try to apply general traction and get it in its most common position. Do not release the traction. If you hold traction and they just were like, ah, so, that feels great. Don't let it go. They're going to hurt you. Promise you. Foot injuries, see where they're jumping. That's kind of your common injuries. Toe fractures, can be, I guess that's considered a foot injury if you break your toes. The force of the injury is transmitted to the upper legs and to the spine, reduced to the lumbar. So in here, just because, where is my mouse? When you jump down here, the ball of your feet, it jerks it up to the joints, basically is where the pain's going to be. And you could have some back pain. You may have some injuries of the lumbar area, which is the lower. Y'all should know your spine areas. It's going to be your lumbar, if you notice in here. And they'll complain of hip and back pain. Could have some broken toes, some phalanges. You may have to splint them, like they're saying down there, rigid, an air splint or a pillow splint. Always leave the toes exposed, so that way you know if there's circulation. If they can wiggle a toe, yes, it may be painful, but at least you know there's circulation and they still have sensation of the feet. And that also allow you to just palpate for good movements. Most of the time with feet injuries, a vascular injury is not common. Lacerations about the ankle and the foot may damage important underlying nerves, but they're not common for you to like have an open injury. Now, I've seen people jump so high that they blow their ankles out, their knees and their back. So I don't know how some of these people jump from building to building and then they keep going, because my back's killing me now and I'm wiggling around like a worm in this chair so I can talk to y'all. Strains and sprains, use the RICE method. That is the abbreviation they want you to follow. You'll hear RICE, ice, rest, ice, compression, elevation, and splinting. It's really all you can do for sprains and strains. That's the best that you're going to be able to. Amputations. All right, so here's the thing. If you have to use a tourniquet, it must be high and tight. There is no excuse for it not to be high and tight, period. I don't know many of you if you've had any go with tourniquets. In one rotation in the Middle East, I applied 13 in one rotation. I'm very comfortable with using a tourniquet. I have picked up many limbs and angulated limbs, but tourniquets work if it's done correctly. They are going to be painful when you apply them because they have to be tight. Do not allow any extra material. If you have to cut the clothing out of the way, that's fine. You need direct contact with the skin when you apply these. I'm just not going over these slides because if it's an amputation, let's say it's a finger or a toe, or you want to try to put it in ice. Now, you don't want to put it directly because you can have some damage. You want to put it in a bag and then fill it with ice. Not the bag, the container. Steal somebody's cooler for all that matters. You want to keep the amputated part cool, but you don't want to allow frostbite to happen. I was never able to get anything attached from what I was used to dealing with. It was all like, it's over with. Sorry, you lost that one. So compartment syndrome is probably not what we're going to see. We're not going to see these because it's going to be the case that I hope to hell you ain't dealing with somebody for 6 to 12 hours. If you are and you don't have an ALS provider there, you might want to look for another agency. I'm not being ugly. Not saying that you can't handle it, but you need somebody that's got narcotics there. You're going to have compartment syndrome is because of excessive bleeding, severely crushed extremity, and the rapid return of blood flow to an ischemic limb. And plus you got to think now you're allowing, how do I put that? It's the release of all the contaminants from that limb back into the body is what's going to also create compartment syndrome. Here you are, some characterizations. Characterized by those following. I'll let y'all read that while I get something to drink. So compartment syndrome, if you have a pediatric patient with a fracture below the elbow or knee, look for all of those below. These are indicators that the pressure within the fascial compartment is elevated and it needs to be addressed quickly. If you don't have it done quickly, you're going to be trying to play catch up and you don't have time to catch up for those injuries. If you have a sorry. Next. If you suspect that the patient has compartment syndrome, splint that limb, keep it at the level of the heart, don't go higher, and provide immediate transport. Always check that distal pulse, the sensation, and keep assessment of the vitals. That's very, very important. Stand by one. All right, ladies and gentlemen, as you can probably tell by my voice, that is the end of class. Does anyone of the 14 that are here, any questions, concerns, problems? If you come with a fuss, please come with an answer. Does anybody have any questions? All right, I'm going to take that as a no. All right, ladies and gentlemen, there is your code. Your code for tonight is 9 money sign question mark 88. Let's see if I can type this into the chat tonight, see if it'll actually work. Nope. Somebody type that in the chat for me tonight, please, if you don't mind. 9 money symbol question mark 88. Ladies and gentlemen, it's been a pleasure as always. Pleasure's all mine. It's great to have y'all in the class. Please be aware that if you do not start taking some of your tests, the ones that are missing it, you will get zeros, period. If you're greater than 10 days, you automatically receive 10 points off of your final grade, or off of the grade. Some that are greater than that, and there's some times that I've spoke to some of you, you will not be able to retake your test. Is this the quiz and module code? No, module code is separate. Thank you for saying that, Travis. Stand by. I got to get the module code. Where's it? Stand by, y'all. I'm having to operate this from my phone and I can't find it as well. Oh, Lord. All right. Oh, Lord. It's trying to tell me hang on, let me pull it up on the computer, y'all. It's trying to tell me my grades, and I'm like, I ain't taking a one test for this class. All right. All right, guys, I'm going to say this one more time. You must have everything completed to move on to Tuesday night. If you don't have it, I promise you I will lock you out. You have to have all of your stuff done to move on to the next module. There's 14 of y'all in here. There's not many left in this class. Some of you are not doing too well. Some of y'all are failing now. And some of you are doing very, very well. I have spoke to multiple of y'all. Guys, I need you to make sure that you do all of your tests. I want y'all to do the best ability that you can. I want y'all to ask me questions if y'all can. Mickey, if you can, you help me out there. Travis, I'll get you in the promise in a second, I promise. But guys, I need y'all to please. I'm not gonna baby y'all. I'm not gonna remind y'all individually, hey, you haven't taken class 29. I'm not doing it. I got stuff to do. Y'all got lives to go on. I want y'all to continue in this field. I think it's great. We all grown adults, and I think that y'all can be the best EMTs out there. If y'all need a little bit of pushing, tell me. I'll call you and I'll give you that extra credit, that extra pushing, not credit, because you ain't gonna get it. But I'll give you that extra little chewing that you need to get going. So please tighten up. I don't know how else to say it. I'm not gonna harp all night long because y'all got stuff to do too. So Travis, what does fractures, breaks, etc. do to your vitals? Mickey says the pain will cause increase. When you say increase, like slight increase or become tachycardia increase? A little north of both. That is correct. Your pain will increase that, and it'll increase your respirations. It'll increase your pulse rate. It's going to increase a lot. I mean, really.
I will chime in on that on a little bit of a personal level. I will tell you this, Travis, as a person that has high blood pressure, that anytime that I'm in pain or anything that causes in any type of pain, basically, my blood pressure will raise, my heart rate will raise, everything will raise. That is your body's defense. That is your body's way of telling you, hey, something's wrong, fix it. So that's what you have to look for. That's the one thing that your patient's not going to be able to tell you. They're going to tell you this hurts, but they're not going to be able to tell you, hey, my blood pressure's high. So you have to look at that.
Travis, does that help any? Does that help any of y'all? Please, any of y'all comment. Also, I'm gonna tell y'all while I got y'all's attention, at least 14 of y'all. Next week, I am going to be unable to be reached. Rob is aware. I will pre-record your lectures and I will post them on. You're gonna have to watch them off the YouTube channel. So make sure y'all are gonna have to do that. I have some things that I have to take care of and do for myself and the family. So I will not be reachable. If you message me on Facebook, probably not gonna answer you. If you can email me, I will forward that email on to Rob. If I can't answer you, I will, but I'm taking some time. I gotta get some things situated. All's good. All's fair and well. I still love you faces. That's since I don't know any of y'all, but I still love y'all to death. It's been great. It's been fun. But y'all know we don't have that many classes left. Not at all. We don't have much of anything left with each other. I know that I won't see y'all for the chapter for the final, but tonight is what, 31? We have 3 more to go. 3 more chapters. I know. I'm still talking, Travis. I got it. Mickey's gonna help me out since I can't type. But y'all tighten up. I promise you, if y'all saw my Facebook post tonight, I'm not trying to be ugly. I'm trying to hold y'all accountable. Y'all grown folks. You gotta do grown folk jobs right now because we expect y'all to get out there and save lives. Hope to God it's not mine one day, but you're class code tonight, Cherry, is on the screen right now. It is non money symbol question mark 88. For your module code, Nikki, can you type that for me if you don't mind? But your module code, where if I can get it pulled back up, for you have to have this class done. It's limited. It will lock. What is tonight? 5 days from tonight. So your test and your module test will lock on the 20th, and that's it for your module exam. But your module 4 exam is 1-4-M money symbol. That is for your module. So 14 of y'all should be writing that down. Well, actually 13. Unfortunately, I had to send Mickey a picture so she could type it for me. But that's your module code, all right? Your class code is different. Your class code for tonight is on the screen, and we've said it multiple times. Please, yes, everybody's typing it in there. That's wonderful, y'all. So y'all know to take your module. I'm going to ask it again. If y'all have any questions, y'all need anything before you take your 100-question module test, reach out before next week. I'm here. I will help you. As long as I'm not outside working on the deck here, I'll do what I can to help you. I will not give you answers, but I'll steer you in the right direction. Travis, last question. Shoot it, sir. That is correct. Your final exam, I can promise y'all can ask Rob all y'all want. You can do whatever you want to do, but he does not know the class codes. I'm the only one that knows them. I love him. He's a great guy, but he's super busy. Rob will get your class final code. That's why you have to take a computer or what you've been taking your finals on, your test on, to the boot camp. You will not be able to take your test until you are at boot camp, period. You can ask me, you can bribe me. I don't know how much money y'all got. I mean, I'm just saying, we might be able to. Now, I'm just picking. I hope y'all know that. But you got to take your final in person at boot camp. That's all it is, period.
Well, I mean, Chris, after everything we have spent on the class and uniforms and everything else, I think some of us might be able to pull together and bribe you. Because I mean, if anybody went to Academy to buy their pants,
Travis said it, bro.
They are $50 at Academy.
I know. Y'all, I'm not trying to,
And the shirts are 25.
I don't even have one of those shirts. Come on.
Well, they only getting one from me.
Well, y'all, I just hope y'all know I'll do everything I can to help y'all, but I will not baby you. I got stuff to do. I got a family to take care of. Y'all got stuff to do. Y'all got jobs. Y'all maybe work 2-3 jobs. I feel you. But I'm not
But
going
what if I leave my blankie at home, Chris?
Hey, I'm not going to be there, so it's not my problem.
I mean, I'm just asking.
I love y'all. I'm telling you. I mean, I'm gonna be 161 miles out in the Gulf. I can FaceTime y'all and be like, "Good luck. Let me know." But there's certain things as an instructor I can't help you with because y'all are at your finals.
Bro, you better be on FaceTime during these clinicals. You been here this whole time.
Yes, y'all know y'all can reach out to me. I promise you that y'all can reach out. I've spoke to several of y'all by Facebook, emails. I don't know if y'all notice when I'm at work, I go to bed super early. Like if I'm off, I'm in bed right now because my morning starts at 4 a.m. So Sometimes y'all have emailed me 9, 10 o'clock at night. My phone goes off, my watch vibrates. I get up and answer your emails because that's my job as an instructor, is to do what's best for my students. I wish I knew y'all's faces. Yeah, I have spoken to somebody at 4 a.m. too. But y'all got to tighten up too. I'm fussing at all y'all. I know some of y'all's grades are amazing, but again, I'm gonna shut up. Y'all got stuff to do. Some of y'all are at work. Some of y'all doing other stuff. But y'all please message me if y'all need anything. Um, I You got the codes. You've been given the codes. Folks, I hate to be ugly. I hope y'all write them down, because there's a group of time that I'm checking some lists twice. It's not Christmas, but I keep track of who's in the class, when they in the class, and if you're not in here, you're gonna have to watch the whole video to get the code. So that's on you. Don't just text me and be like, "Oh, I forgot it," because I know who's been in here this entire time. It's gonna be all right, folks. Marty, Henry, Travis, all y'all. Mickey, I appreciate every one of y'all. Thank y'all so much. I hope y'all have a great evening. I'm gonna turn the mic off a little bit. If y'all need something, uh, please message me, hit me up on the side of Facebook or whatever else. But I'm gonna turn the mic off and let y'all take some pictures. Y'all have a wonderful night. Good luck in your test, and don't forget your other ones in your final or your chapter. Good night, y'all.